So I have the honor to welcome you here today and steer us through the exciting program we have in front of us. My name is Flemming Conrads, and I work at the Novo Nordisk Foundation, it's called. It's a Danish enterprise foundation, and I also have an affiliation and work at the University of Copenhagen. I have been active in the acute pesticide field for quite some time, and I think that's why I've been asked to step in today. I think we probably need to close the door because there's a little noise outside. Okay. So I hear we are waiting for a few more from Guyana. I think I'll start by a few introductory words. Sorry, All right. So we are gonna discuss this important topic with our honorable ministers, also distinguished delegates from various countries. We also are fortunate to have representatives from WHO, UNEP, academia, civil society, and many other stakeholders in the area. Maybe I should also point towards, say, words of appreciation to the governments of Sri Lanka, also Guyana, Kenya, Nigeria, and Pakistan, who have been involved in arranging this event, and also in general countries that have taken a particular interest in the topic of today. Many of you have probably followed the general NCD debate, mental health NCD debate, over the past year, at least since the high-level conference in New York. And it's nice to see that mental health is getting more prominent, and that includes also the challenges of suicide and suicide prevention. The topic we are gonna discuss today with various interventions, the challenge of pesticide suicides, is an issue that doesn't get the attention it deserves. About 20% of the global suicides relate to pesticide, the intake of pesticides, which is not widely known, I would say, in media, in a lot of policy circles and so on, but under discussed topic, so lots of appreciation for governments and organizations, of course, everyone here in the room, for taking time to discuss this. I think it's also important to say, when I first started out working in this field, and many of you would know this better than I do, suicide is, if people want to kill themselves, they will go ahead and kill themselves. From my experience working in the field, many different places, especially in East Africa and Southeast Asia, it's moments of despair, it's desperation. Many, if not the vast majority of pesticide-related suicides are preventable. And that's, I think, we need to keep at the forefront. We have many success stories. Sri Lanka is one of those success stories where action have been taken and significant reductions have occurred. So it's an area that needs more attention. It's also an area where we know we can do something to reduce the burden of pesticide-related suicides. So that was just a few introductory remarks, and maybe also stressing that you will meet and greet later on, and some of you have already connected, and it's obvious from this topic that it's intersectorial: agriculture, health, education, lots of different sectors are involved in shaping this challenge, but also shaping the solutions. Before we turn to our other distinguished guest, Joe Robinson would like to make a short introduction, president of the International Association for Suicide Prevention, obviously super relevant for this topic. And I think you have been called upon to talk about the role of pesticide poisoning in the wider landscape of global suicide and suicide prevention. 7 minutes dedicated to this big topic. A warm welcome to you, please. Welcome.
Thank you so much. Thank you for having us here this evening with you all. Honourable ministers and dignitaries, colleagues and friends. Every year, almost 750,000 people take their own lives, and many, many more people make suicide attempts or live with suicidal thoughts or feelings. Every suicide is a tragedy that impacts families, communities, and entire countries in the most devastating way possible. And it can have a long-lasting effect on those left behind. Suicide is the third leading cause of death amongst young people globally, and in many countries, like Australia, where I live, it's the leading cause of death in our young people. These deaths are an absolute tragedy, and in most cases, they're preventable. But suicide doesn't just occur in high-income countries like Australia. In fact, almost 3/4 of the world's suicides occur in low and middle-income countries. And whilst in many countries, again, like Australia, suicide is conceptualized as a male problem, many of the suicides that occur in low and middle-income countries are by women, often using pesticides. As such, suicide is a serious public health problem that requires a serious public health and societal response. Increasingly, this is being recognised, with governments acknowledging the need to tackle the social, structural, and commercial determinants of suicide. But what does that look like in our modern world? A world of global conflict, cost of living crises, food and housing insecurity, social media, and artificial intelligence. Our own work at Origin in Melbourne has shown that young people attribute their poor mental health and risk of self-harm and suicide to factors including cost of living, housing insecurity, racism and discrimination, and climate anxiety. They also told us that the biggest barriers to seeking professional help was cost, wait times, and shame and stigma. This leads many of them to seek support on social media and via unregulated OpenAI chatbots and other tools, even though their preference is really to speak to a fellow human. And that's in a wealthy country like Australia, where we have national and jurisdictional suicide prevention strategies and where suicide can be talked about openly, and we have a high-quality mental health care system. So it's easy to feel overwhelmed and pessimistic, but we know intervention works. We know that when we target investment in the right way, that we can reduce rates of suicide, self-harm, and suicidal ideation, and support those living with unimaginable distress, as well as their families. Targeting pesticide poisoning is an excellent example of an approach that, when implemented at scale and in a sustained way, can prevent tens of thousands of deaths. Similarly, decriminalising suicide can reduce stigma and discrimination and facilitate help-seeking amongst our most vulnerable. But we also need targeted approaches for those at risk, early intervention and support for our young people. And the WHO Live Life framework sets out many of these approaches. Many of you will be familiar with the 4 pillars of Live Life. We talk about means restriction, which we've been speaking about and will speak about much more this evening. But more broadly than restricting pesticides, we know that reducing other methods of suicide also works. The evidence is clear. Live Life also talks about media guidance. And again, we know that responsible reporting that promotes help-seeking, hope and recovery can make a big difference in suicide prevention. But what's next when it comes to media, including social media, AI, and other forms of digital technologies, both in terms of their potential for harm, but also their potential to help. We've just done some work with WHO examining digital environments for youth mental health and setting research priorities, and I do encourage you all to have a look at that work. And there are also pillars on life skills and early intervention. So equipping with young people with the skills to navigate the world and look after their mental health, and building systems of care. And this isn't just about bricks and mortar clinical or hospital settings, as much as it's critical that those systems and services work well. We all have a right to high quality evidence-based care when we need it. But when thinking about this for people in different contexts and for young people, there's a need to take suicide prevention efforts to them where they are, whether that's online, in schools, or in communities. But at the same time, have health services and crisis support services co-designed with them in mind. This means involving them and all of those people with different types of lived or living experience in co-designing our local, national, and global approaches. So what are our next steps? We need to tackle the big challenges that we're facing as a global community, and that means new and bold approaches. It means working together across governments, including people with lived experience. And it means international collaboration and leadership. And this is happening. Just the number of mental health and suicide prevention events here at the World Health Assembly this year shows that this is a key priority for governments, NGOs, and civil society around the world. But with almost 2,000 suicides every day, there's always a need to do more. I'm proud to say that IASP, alongside WHO and our other colleagues here tonight, we are doing our best to tackle some of these challenges. We have programs targeting decriminalisation of suicide, programs to support countries to develop national strategies, and task forces on AI and suicide prevention in women and girls. We're here to help, and we encourage all of you to join and reach out if we can help, support, and amplify the great work that you're all already doing. With timely, evidence-based, and coordinated interventions and approaches, suicide can be prevented. I want to thank you all for being here and for the work that you're all doing. And I do believe that if we work together, I'm confident that we can see a world without suicide. Thank you.
Thank you so much. We have a small 5 minutes video we would like to share with you, a lived experience story. I think we have a support in the back. I should say in this movie there are distressing issues being brought forward. There's also a help number being mentioned at the end of the video. And let's see if we can see it now. You're welcome to go there, and it will take 5 minutes. Thank you.
Buddhang saranang gacchami Tatyampi dhamman saranang gacchami මගේ නම ශ්‍රීමල් ලහිරු මදුසංක මගේ වයස අවුරුදු 31යි මගේ ගම එප්පාවල මගේ පවුල ඉතින් මමයි වයිෆුයි බබාලා දෙන්නයි
මගේ නම කේ හර්ෂණී මදුෂික මට දැන් අවුරුදු 28ක් වෙනවා මේ ගෙදරට ඇවිල්ලා දැන් අවුරුදු 5ක් 6ක් වෙනවා ලොකු දෝනි හම්බෙලා අවුරුද්දකට විතර පස්සේ මෙහෙට
මොකද එදා උනේ?
දවුනේ කොහොම හරි අයියයි මායි අතර පොඩි රණ්ඩුවක් වුණා. ඊට පස්සේ අයියා වැඩට ගියා. අම්මත් කොහේ හරි ගියා. කොහොම හරි අර පීඩනේ තමයි. ඉතින් අර මෙහෙ පුරුදු නෑ පරිසරය. තනියම එහෙ ගොඩක් අයත් එක්ක ඉඳලා ඇවිල්ලා තනිකම පාළුව. මොකද අර සැහැල්ලුවෙන් හිටපු ජීවිතේ එකපාරට මෙහෙට ආවට පස්සේ හිර වුණා වගේ වුණා.
එදා ඉතින් වයිෆුත් එක්ක ඉතින් බහින් බසීමක් ඇති වෙලා මම එයත් එක්ක පොඩ්ඩක් රණ්ඩු වෙලා තරහට ගිහිල්ලා වයිෆ් වහ බිව්වේ. එතකොට අපි දන්නේ වයිෆ් ප්‍රෙග්නන්ට් වෙලා කියලා. එහෙමනම් කවදාත් හිතුවේ නෑ වස බොයි කියලා. අපි ගොවිතැන් කරනකොට ඉතින් එයා දන්නවා අපේ වස තියෙන තැන් දන්නවා. ඒ විදිහට එයා ඉතින් ඇරිදා රණ්ඩුවක් ඇති වුණ නිසා එයා ගිහිල්ලා ඉතින් එතනට ගිහිල්ලා වහ කුප්පියක් අරන් ආපු තරහට ඉතින් බිව්වා ඉතින්.
අර පීඩනෙත් එක්ක තමයි ඉතින් ඒක බීලා හරි මැරෙයි කියන ඒකෙන් තමයි ඉතින් ගිහින් ගත්තා අරගෙන බිව්වා. එච්චරයි ඉතින් අර තේරුමක් නෑ වස කියන්නේ මොකද්ද මේකෙන් වෙන්නේ කියලා. අර මැරෙන චේතනාව තමයි ගොඩක් තිබ්බේ හිතේ. දැන් ජීවිතේ සතුටුයි. මොකද දැන් තනියම ඉන්නේ. අපි 4 දෙනා විතරයි. කවුරුත් ඇඟිලි ගහන්න නැහැ. අපි දෙන්නගේ ප්‍රශ්න අපි දෙන්නගේ ඇතුළේ ඉඳගෙන එහෙමයි. ඒ කාලෙට වැඩිය දැන් හොඳින් ඉන්නවා.
ගොඩක් ඉස්සර නම් හැබැයි ගොඩක් වස බිව්වා. ඊට පස්සේ වස පොඩ්ඩක් පාලනය කරාට පස්සේ විස දේවල් අඩු වෙලා තියෙනවා. ඒකෙන් ඉතින් මිනිස්සු වස බොන ප්‍රමාණය අඩු වෙලා තියෙනවා. බිව්වත් හානියක් වෙන්නේ නැහනේ. ඒ බීපු වසේ තෙල් එකේ සැර අඩු නිසා එයා බේරුණා. නැත්තම් එහෙම ඉතින් මැරිලා නෑ.
Thank you so much. I will call upon one of you at a time, but I think this is a good opportunity to call upon our minister from Sri Lanka. Please step forward and take a seat. Honorable Minister of Health and Mass Media, Government of Sri Lanka. It's an interesting background because, as I mentioned in the beginning, Sri Lanka has done an amazing job in this area, pesticide-related poisoning. So a great honor to have you in the room. I also know you have to leave us for other arrangements, so I'll give you the word, please. You can sit or stand, up to you.
Good evening to all of you, honorable ministers, ambassadors, distinguished delegates, colleagues from partner organizations, ladies and gentlemen. Sri Lanka stands before you today not simply to share a story of progress, but to offer the world a proven replicable and affordable blueprint for one of the most urgent and overlooked public health crises of our time, death by pesticide self-poisoning. The number you can see, 93,000, is not a guess. It's a conservative, peer-reviewed estimate of lives saved over 2 decades through regulatory action that cost less than $50 per life saved. $50. It is also conservative because it ends in 2015. The sum in 2026 is nearer 150,000 lives saved. The second slide, to understand what Sri Lanka achieved, we must remember what we faced. In the late 1980s, Sri Lanka had one of the highest suicide rates in the world, approximately 60 deaths per 100,000 people. At the peak, pesticide poisoning accounted for 76% of all suicide deaths. That is roughly 700,000 deaths by suicide, pesticides. This was not a mental health crisis alone. It was a crisis of access to a lethal means freely available in homes and on shelves throughout the country. I think you can understand it well by this, the previous story. The suicide rate had risen 8-fold between 1950 and 1995. Communities in our farming heartland were devastated. Families were losing breadwinners to impulsive acts with immediate, irreversible consequences. Sri Lanka's response was grounded in a simple but powerful insight from the sense of suicide prevention. If you remove the most lethal and accessible means, you save lives, because most suicidal crises are time limited and survival gives people a future. Our policy response was not a single intervention. It was a decade-long, evidence-driven architecture of legislation, regulation, and institutional commitment. It began with the Control of Pesticides Act in 1980, the foundation that gave Sri Lanka the legal authority to act. By 1983, we had begun banning the most highly hazardous pesticides. From 1994 to 2020, those bans were strengthened and expanded through rounds of legislative reviews, each informed by surveillance data on which pesticides were causing the most deaths. Critically, in 1997, Sri Lanka integrated pesticide regulation directly into our national suicide prevention policy, recognizing that means restriction and mental health action must work in tandem. And today in 2026, we are launching our medium-term pesticide risk reduction strategy, our most ambitious commitment yet. A 90% reduction in acute pesticide deaths by 2030 and 0 deaths by 2035. This is what sustained political will looks like across governments, across decades. The results speak for themselves. A 70% reduction in Sri Lanka's national suicide rate between 1995 and 2017. 55 hazardous pesticides banned or restricted since 1983. And critically, 0 measurable impact on agricultural productivity. This is the point that skeptics always raise, that banning pesticides will affect food security. That's a big controversial argument in between these certain companies and the health sector. Sri Lanka's evidence proves otherwise. Properly designed actions backed by evidence and sound scientific principles for sustainable transition to safer alternatives cause no harm to agriculture. In 2021, our pesticide regulation policy was recognized with the Future Policy Award, described as the Oscar of global policymaking, awarded by the World Future Council and FAO in partnership with WHO. This recognition mattered not for its prestige, but for what it confirmed, that Sri Lanka's approach is now regarded by the global community as a global standard model for pesticide-related suicide prevention. But our work is not complete. Between 450 and 500 people still die by pesticide suicide in Sri Lanka each year. And it remains the second leading cause of suicide in our country. A small cluster of legacy pesticides permitted before modern regulation tightened now accounts for 64% of identified deaths. Carbosulfan and profenophos alone are responsible for a disproportionate share of fatalities. These are the targets of our next phase of regulatory action. Occupational poisoning is also a serious concern. Only 10% of farmers currently use proper personal protective equipment. Pesticide residues are being detected in export crops, threatening our access to international markets like EU and the Middle East. And chronic health effects, including from potential carcinogens still registered for use, remain poorly understood. The agenda is unfinished, but the path is clear. Our National Pesticide Risk Reduction Strategy 2026 to 2030 is built around 6 integrated pillars, as you see in the slide. First, strengthening regulation by targeting the small number of highly hazardous pesticides responsible for disproportionate harm. Second, supporting safer agricultural alternatives through closer collaboration with the agriculture sector. Third, improving healthcare readiness and mental health support to reduce deaths and reach vulnerable individuals earlier. The strategy also focuses on training and enforcement, strengthening surveillance and evidence systems, and expanding collaboration with WHO, FAO, and international partners to advance the goal of zero actual pesticide deaths. These measures are practical, evidence-based, and ready for implementation, and we look forward to continued global partnership in this effort. Let me close with 3 direct messages from Sri Lanka to this global community. First, evidence-based regulation of highly hazardous pesticides works. Sri Lanka stands ready to share our experience, technical expertise, and evidence with countries facing similar challenges. In this audience, Mr. Dunavila, he was agriculture ministry, the high official in this time, and he knows the challenges we faced at that time. Second, we encourage the global community to advance zero acute pesticide deaths as a measurable SDG-aligned goal that brings together health, agriculture, and development sectors. Third, the time to act is now. Pesticide self-poisoning continues to claim thousands of lives each year, despite clear evidence that these deaths are preventable. Sri Lanka transformed a national crisis into a public health success story. With continued global cooperation, evidence-based policy, and political commitment, we can save many more lives. Thank you. This is a collective effort. It's a global challenge and global effort. I think we can write a success story with all the supporters. Thank you.
Thank you so much, Dr. Jayatissa, Honorable Minister. Thank you so much. Sri Lanka is in many ways, as you just pointed out, a blueprint, and for us to follow in the room. It's also a fantastic example of research working with policy, and I think there are quite a few in the room that can have contributed to this success story, but I'm so pleased you had time to come and present it to us today. It's great to listen to, and I think we'll have other good examples being presented over the coming hour or so. Let's hear next. I know our Minister of Health from Guyana has not yet arrived, so we'll move to Dr. Tunde Oje, National Coordinator, National Mental Health Program in Nigeria. Please join me up here.
Thank you so much. I will be reading the Honorable Coordinating Minister's speech. So thank you so much once again for having us to be co-host of this, co-sponsor of this great event. Distinguished Chair, Honorable Ministers, Excellencies, representative of the World Health Organization, the Center for Pesticide Suicide Prevention, University of Edinburgh, Novodesk, and other people that made all this happen. It is an honor for Nigeria to participate in this important side event at the 79th World Health Assembly, focused on the prevention of pesticide-related suicide, a major yet preventable global public health challenge. I wish to sincerely commend the government of Sri Lanka, Guyana, Kenya, as well as United Nations Environment Program, the International Association of Suicide Prevention, and the University of Edinburgh for bringing global attention for this urgent issue. Nigeria recognizes suicide as a major public health and development concern. We also acknowledge that pesticide self-poisoning represents one of the most lethal methods of suicide, particularly in low and middle-income countries, where highly hazardous pesticides remain easily accessible. The evidence before us is compelling. Countries that have implemented effective regulatory measures on highly hazardous pesticide have demonstrated remarkable reduction in suicide deaths. This experience reminds us that suicide prevention is not solely a health sector responsibility. It is also a matter of sound public policy, chemical safety governance, environmental protection, and social justice. Nigeria has made important progress in strengthening mental health governance and suicide prevention in recent years. A major milestone was the enactment of the National Mental Health Act in 2022, which provides a modern, right-based legal and institutional framework for mental health care delivery and the protection of human rights of people living with mental health conditions. Knowing that suicide is not just about mental health, but that mental health constitutes a very big nexus between suicide. So, promotion of community-based care and advancement of suicide prevention efforts. We reviewed our national mental health policy and developed a national suicide prevention strategic framework, aligning with global targets and imperatives. Importantly, Nigeria has also taken progressive legal steps towards the decriminalization of attempted suicide. For a timely completion of the process, Nigeria set up a national task force that is given the mandate to see to the decriminalization of attempted suicide within 2 years. And we are close to achieving this. Just the federal executive bill has already been transmitted to the presidency, and we are close to this. And this is informed by learning from countries that have been very successful at decriminalizing attempted suicide. And so we are able to learn what to do, how to do it, and what not to do. And so we are optimistic that in less than 2 years, with our counting time from 2025, we will be able to decriminalize attempted suicide in Nigeria. Nigeria is also, thank you. Nigeria is also increasingly recognizing the intersection between hazardous pesticide exposure, intentional self-poisoning, occupational risk, and broader environmental determinants of health, and has put in place a framework that limits access to harmful substances, use of it for suicide. However, significant challenges still remain. Data on pesticide poisoning and suicide in Nigeria, as in most low and middle income countries, remain fragmented and underreported. Weak toxicovigilance systems, limited poison control infrastructure, stigma, and inadequate surveillance continue to obscure the true magnitude of the problem, particularly in rural and agricultural communities. This is why Nigeria strongly supports enhanced collaboration between ministries of health, agriculture, environment, and regulatory authorities to improve the following: surveillance and reporting system, public awareness of safe pesticide handling and storage, regulation of highly hazardous pesticide, access to emergency treatment and mental health care, research and evidence generation to guide policy actions. Distinguished participants, suicide prevention is achievable. The experience shared globally, including, very importantly, from Sri Lanka and other countries, demonstrate that evidence-based regulation saves life. Nigeria therefore calls for stronger global cooperation on pesticide regulation, technical and financial support for low and middle income countries, expansion of suicide surveillance and poisoning information system, greater investment in community mental health services, as most of the suicide that happens in the communities. We must collectively act with urgency, compassion, and evidence-based resolution. Every life lost to pesticide-related suicide is one too many. On behalf of the government of the Federal Republic of Nigeria, I reaffirm our commitment to working with member states, WHO, academia, civil society, development partners, and others to advance suicide prevention and protect the health and dignity of our people. To put action to our resolve, there is a joint ministerial statement, and we enjoin member states to sign on so we can take our commitment to the next level. Thank you for your attention.
Thank you so much. Thank you so much, Dr. Tunde, Federal Minister of Health, Nigeria. We have another presenter, Dr. Isaac Bashar, Kenya Director, Family Health, Minister of Health, Kenya. No? Then we are fortunate, I think, to have Khan, public health expert from WHO Pakistan. Welcome.
Bismillahirrahmanirrahim. In the name of Allah, the most merciful, the most beneficent. Sir, it is my duty here to express my gratitude and thanks to the organizers of this event. Very important, close to hearts of all of us. Unfortunately, our minister couldn't make it because he is in another meeting where the regional director is there. So regional director is actually the head of 22 countries, so he has to be there. So that's why I will speak not on behalf of the minister, but on behalf of WHO, because I cannot speak on behalf of him. But we talked to the ministry on this very topic. We shared the joint statement with them, all the data, and we got their nodding. Yes, they are with us in controlling the suicide, not only the suicide, but entire NCD. So I will just start by saying that Pakistan is a huge country of 260 million people. It's a huge population, and the major chunk of the population is consisting of the youth. And as you all have said, that this is problem primarily of the youth, particularly youth is most affected by this suicide, poisoning also, but committing suicide also. After seeing this small video, very moving one, I will just make one comment or reference to one of the very, very tragic story. There are so many. Although we have very limited number reported in Pakistan, because of many reasons, we don't have very strong, robust health system to have the records of all the suicide cases. And most of the time, these are not reported by the families also, you know it very well. There are so many factors which are to be tackled. Not only the problem itself, but the determinants of the problem that should also be actually taken care of. I will say that there was a gentleman, a young boy, very brilliant student of 18 years in Kashmir. He committed suicide. And everybody was jolted because it was widely covered in the newspapers. And myself and my colleague Mamuna, we were there because we are having our MH GAP program, Mental Health Gap Action Program, in which we have a module on suicide also. So under the gob of that, we were there, met with the authorities also, met with the families also. The small story which we were actually told was that he was very brilliant in his early school. When he entered in the college, his grades were lowered and he was, I think, upbraided by the teachers or by the community. So he suddenly, his family was not knowing it. He was living in the hills, and in the morning, his father found him hanged in the tree. And then they knew that he has committed suicide. He just left one liner or two-liner paper for his family. But this was the problem. Then we met with the inspector of the area, who actually lodged the FIR and made some investigations. But he was not knowing about any law of decriminalization at that time. And now again, this is not the law in Pakistan. It was there, but day before yesterday, it was set aside by the Shariat Code. Unfortunately, we all will have to work together to actually, again, make up our efforts. So having said this and showing our commitment with the joint statement also, with the cause also, I would say that it is time actually to work together with those forces actually who are against the decriminalization of this act. That is why the court actually ordered in favor of them. So we should work with all the forces who are actually creating problems, making hurdles on the way to decriminalization of the law. That is one thing. The other thing is that we need to actually involve all segments of society, as was discussed, that this is not the issue of only to be dealt by the Ministry of Health or WHO, but all the partners, all those who matter in the countries, in the society, they should be taken on board. And I would say here that the religious people, they should be there, because in our religion, Islam, it is haram. So committing suicide is haram. But still people are doing. So why not to actually motivate those people and bring them on board with us? Unfortunately, the appeal that was filed in the court, that was again by a religious organization. Religious and political organizations. So need to work with them, because if we are all together as a team, we all will be achieving. Together, everyone achieves more. This is what actually team says. So we should be as a team work. And in Pakistan, we have done some work with CPSP. We are thankful to them. We have worked with other organizations also. And the data is the main problem. We are really glad to see the figures from Sri Lanka and their achievement. I think it is, they have taken 20 years, I think, to reach to this 93,000 lives saved. So we are actually now embarking upon that path, but we would certainly be benefiting from the experiences of other countries. the stories which we have, the success stories, these will really help us. And I would say on behalf of WHO and my country head also, we are all against those who are creating problems, and we will continue our journey towards suicide-free society, and we will continue our journey towards de-stigmatization of this very act, because this is the problem. This is not the young Hasib who died. Actually, the entire family died because he was the only young person in the family. And we are seeing that so many breadwinners, they are doing this. Every now and then we are seeing in the newspapers, people are committing suicide. Even the families are committing suicide. Mother with child, with 3-4 children, they're jumping in the river. I'm citing the example of Jhelum Neelam River in Kashmir, where most suicidal cases are occurring these days. People commit suicide, they jump in the river. What are the reasons? So we are actually working with the local authorities there, with the Ministry of Health, and everybody is there. The good news is that now Ministry of Health has a technical working group on NCDs, because WHO has now made mental health as part of NCD. It is 5 by 5, 5 diseases and 5 risk factors. So mental health is one of them. So, and also we have the alliances with the national, the authorities, health authorities in that area, and also with the police department. We are embarking upon some capacity building activities to actually make them aware of not only the problem itself, but also the solutions. How can they help? How can they join the health department? How can they bring other departments on board? And likewise, we are also working with the Ministry of Agriculture, and for the chemical safety, and my colleague is here, we were discussing this, and we will be seeking his help also in making some of the hazardous pesticides away, because the means of committing suicide should be taken away. The prevention is the only answer. We cannot treat, we should prevent, because spending $1 on prevention saves $7 in NCDs, including the suicide. So with this, I will say that we are fully committed. Pakistan is fully committed towards the cause of reducing the number of suicidal cases in Pakistan. And I'm sure that the Ministry of Health would definitely be on our side, and they will definitely be expressing their views later. Thank you very much.
Thank you so much. So it's nice to have the perspectives from Pakistan, and Khan, thank you so much for coming and representing, of course, Pakistan and WHO at the same time. I will, in 2 minutes, two presentations, I'll call upon people in the room to make brief interventions. I know we have experts from Brazil and Honduras and, of course, Bangladesh, and also researchers in the room that will be allowed to come with brief interventions. But we also have 2 other presentations, important. Richard Brown from Chemical Safety and Health Unit of the World Health Organization. I'd like to bring you to the floor and give us your perspectives. After that, we'll hear from UNEP, and then we'll open up from the comments from the floor.
Thank you very much. Ministers, Excellencies, colleagues, thank you for this opportunity. Thank you to the Centre for Pesticide Suicide Prevention for giving the opportunity to speak and talk about WHO's work in this area. I was asked to give a global perspective on what is the burden of fatal pesticide poisoning. How many deaths result from pesticide self-poisoning? And unfortunately, it's difficult to study. We don't have good data on that. Under the Sustainable Development Goals, we have a target, 3.9.3, on unintentional mortality. And we have good data collected on that every year. But it's not possible to break down those numbers to determine what is as a result of intentional poisoning from pesticides. So that's a gap. We also have a gap in we don't know what are the accidental and the occupational injuries and deaths from pesticide poisoning, which is equally difficult to study and is a significant public health problem. So we rely on academic research, good academic research. And as we heard the example of Sri Lanka, when a lot of work is done, you can get good, reliable data. But unfortunately, that's not the case in many countries. You heard from my colleague in the WHO country office in Pakistan that they will try to do this, but it's not easy to do. So it's not easy for me to give you a number. We rely on epidemiological data to make these kinds of estimates. There's limited epidemiological data available, and using that, WHO has made estimates of the scale of fatalities, but it relies on modelling. It relies on a lot of estimate work, so there's a lot of uncertainty. Most recently, this was done for data based on 2019, and it said, through those estimates, 138,000 deaths. We don't anticipate carrying out further updates of those numbers from WHO because of reorganisation in our organisation. We don't continue this work at the moment, but our methods are published. And so with the right kind of academic data being done, so long as rigorous methods are used, preferably systematic approaches, in the key countries where this problem is occurring, then it's possible to update and revise those numbers. And we encourage those in a position to do so to carry out those kinds of estimates. We think universities can do this. The Institute for Health Metrics and Evaluation could do this. But whatever, even though we don't have the precise estimates, we know it's a substantial number, and we know that it's preventable. Now, WHO, through the World Health Assembly, using our authoritative methods, has established that regulatory controls on pesticides is a cost-effective method for addressing this problem. Highly cost-effective, because it's a small amount of regulatory work producing a large-scale impact on health. So what can WHO do to help support this? We collaborate with partners. We have, working with FAO, with UNEP, with the UN Development Programme, we have launched a global alliance on highly hazardous pesticides, as mandated by some of the international conventions. We're working to strengthen poison centres in countries and toxicovigilance systems, as was referred to by the Honourable Minister from Sri Lanka, and have those poison centres report to the public health system. This gives broad health benefits, but also should improve the availability of data to understand the scale of the problem that we have. We also work with colleagues to improve the treatment of those who have been poisoned to help ensure that they survive. WHO can provide authoritative information to member states on this topic and also on what are the most hazardous types of pesticides. Through the WHO recommended classification of pesticides by hazard, we try to do that to highlight these are the most acutely toxic products. Maybe you don't want to use these in your regulatory system for that reason. Trying to update that system to take account of which pesticides are really the most acutely hazardous to humans from human poisoning experience. Feeding that information not just to member states, but also to other actors like supply chain actors, sustainability standards, certification bodies. Because if they say you shouldn't use these pesticides in your product, your textile, your timber, your food in the supermarkets, farmers won't use them because they can't sell their product. So they'll stop using those products. Even if legally they might be possible, you don't even have to go as far as a ban. If a major retailer says, we will not permit this pesticide in our food, the market for that pesticide disappears anyway, even if it's legally permitted. So there are different routes to achieving taking these most hazardous pesticides off the market. So finally, to emphasize, fatal pesticide self-poisoning is a preventable thing, and effective, cost-effective methods have been identified to do something about it, to address this. Thank you.
Thank you so much from that global perspective, from a health global perspective. We'll now hear another global perspective from United Nations Environment Program. Please, Ms. Jacqueline Alves, Chief UNEP Chemicals and Health Branch. Welcome.
Good day to all. It's a real pleasure to be with you here today. And to be honest, I have to start with a big thank you to one person sitting in the audience here, a fantastic Sri Lanka citizen. He used to be a colleague of ours. He's sitting here. He really inspired us in UN Environment to deal not only with the pesticides effects, but also in preventing suicides. I was part of his recruitment process in one moment in time, and he showed this case of how Sri Lanka was doing it. So big thanks, Kamini. I really needed to recognize you. And of course, big congrats to Sri Lanka, being maybe one of the first countries in the world that have passed this legislation. So from my accent, you might realize that I'm coming not from an English-speaking country. I'm coming from a very, very small country where pesticides were typified as medicines. Medicines for crops, medicines for animals, medicines to, in a way, protect food from ants and from other things in the household. Immediate thing that comes with that, where can you find them? You can find them on the shelves. Where? At homes. Where? In a place very, very accessible to children, for example. Of course, children and suicide might not be completely related, but in a way, it's very, very accessible. And I was very surprised. I didn't know that statistics, that only 30 minutes before a suicide is going to take place is when a person decides that they want to commit suicide. So committing suicide, having that poison very accessible to them, is like a very, very easy thing to do. So you might be asking yourself, what has environment to do with suicides and pesticide suicides? So for that, I have to tell you and repeat, because it has been said before, suicides from pesticides is not only a public health issue, it's also a critical challenge for societies. Societies that manage chemicals, because pesticides are not medicines. Pesticides are chemicals. And as chemicals, we need to deal with them in a very, very serious manner. What I'm trying to come here is that we need to use them safe and sustainably. That's very easy to say, very hard to tell. And what are potentially those things that we realize if we zoom out? You have also heard very strongly that suicides are related to social disparities. They are related maybe to the lack of jobs. They are related to frustration, and it was very compelling, the video that was shown at the beginning. Any difficulties can immediately trigger certain decisions. It's related to mental health. And mental health, as you know, last year in the United Nations General Assembly, there is a resolution that connects non-communicable diseases with mental health and well-being. So it is a very, very serious thing. But now, coming back to the question, what does environment has to do with suicides and pesticide suicides? Well, ladies and gentlemen, biodiversity laws. You don't have soil that it's as fertile as it used to be. You have droughts, you have floods, you have climate change things. You have the ecosystem services changing, radically changing because of all of those determinants in the environment. So stop, in a way, taking the picture. You all know all of these things. So what are we doing at in the international community? So this is a very serious thing for UNEP, but it's not only for UNEP. As Richard was saying, it's for the whole international community. 2023, September, Bonn, I'm saying this very slowly because a global framework on chemicals and waste that deals with pollution was adopted by everyone. Like the SDGs, it's not only member states, it's every stakeholder that deals with chemicals. Chemicals being medicines, chemicals being pesticides, chemicals being antibiotics, chemicals being, in a way, all of those things that are contained in products. And you have heard the PFAS situation. Why I'm raising this? Because there is a target, very specific target, that talks about phasing out highly hazardous pesticides by the international community by 2035, where accessible alternatives and substitutes are available. So, fantastic target, we don't know, because it's conditioned to having those resources and those things. So the moment we can start stopping highly hazardous pesticides, that if I come back to what I was saying, that they can be just grabbed and used for suicide, is a very, very big thing. Policy frameworks, we have heard that. Investing in having environmental policies that are appropriate pays. It's maybe one of the things that deliver more in public health outcomes. Why? In a way, because we cannot deal with still having registration of pesticides that are not environmentally friendly, but not only because of the suicides aspect, which is the objective of the situation here, it's also because we are creating chronic effects in the long run, and you all know that very, very strongly. So many different building blocks to address the topic, but don't forget or minimize how, in a way, the environmental determinants are risk factors for these things, because they trigger situations that are not acceptable. It's not only a fight at home, but it's also the frustration of seeing your crops not in a way growing. And what do you do? And this is also an example from my country. Use more. It will not harm. And then you just go back. Who, in a way, washes sometimes the spouse garments? It's the woman, it's the children that are there. So suicide is a big issue. Chronic effects is also very, very important. And you know, most of these things bioaccumulate, they biomagnify, and they concentrate in the bodies. So we are silently killing our offsprings because we have those chemicals inside us, those pesticides inside us, passing through the placenta. So maybe it's not a suicide in the concept of having a voluntary desire to take our lives out, but we are indirectly contributing to killing the most loved persons that we can have, our children, particularly if we are women, because of that effect of bioaccumulation in our bodies. With this, I'd like to stress very, very strongly, prevention is essential. And how to prevent through legislation is one of the biggest elements, but the other one is awareness. People need to understand that pesticides are not medicines. Of course, those that use it with the purpose of taking their lives, they know exactly that they can be killed. But if we have some kind of protection through the government controls or through the different things that we can do, they might not be at reach. They might not be there in those 30 minutes that are compromising ourselves. Thank you.
Thank you very much from that contribution. The UNEP perspective is important. The general environmental perspective is obviously important. So now we are shifting mode a little bit, getting you activated more. We have time for brief interventions, 1, 2, 3 minute interventions, and then think about questions you may have to each other. So it's a time to mobilize your responses. We have a contribution from Dr. Agnes, Dr. Soares from Brazil, Minister of Health. I'll pass the mic to you for a brief intervention.
Thank you for giving me the opportunity to talk. But I was listening to the presentations before, and I think one thing that is not mentioned is that we are dealing here with a very powerful enemy that is the ones who produce the pesticides. And I don't know about your countries, but in my country, this is the most important barrier to do anything that we are doing. So what we decided is that we don't need to prove that pesticides kills, because they should do it, otherwise they wouldn't be pesticides. But what happens is that our data not always help to give a proper advice, and not only to policymakers, but also to discuss this with the other sectors. And unfortunately, recently in Brazil, we had some, I think we went back a little bit, because health has a little influence on what is approved or not approved. But this does not, I think doing health surveillance does not require anyone's approval. So surveillance is our job at the health sector. So what we did and we are doing is to provide even more information than we had before. So we know it's difficult to, and I think very well put, it's difficult to get the cases, but there are other reasons as well. So if we look to mortality, we get part of the data, and if we could look at we have a system that is required, that requires that when there is poisoning, this should be notified. But if you live in a city where the powerful people are the ones who use the pesticides and sprays the pesticides, you are forced not to notify. So it's difficult to get the data, not only because our systems are bad, but because our power to negotiate and to implement what we think should be done is also limited in these cases. But what we are doing is we provided some, we improved our capacity to show the data, and have panels that show this very clearly. And for a surprise, this helped also to show that some pesticides that were banned long ago appear as cause of death. And the ones that are highly hazardous, and some of them that are not, that are considered safe, and they appear as an important contribution to the not only suicide attempts, but also to death. And also, I would like to draw attention, I know I'm going too long on the theme, but I think it is a question of equity, inequities actually. So it's not a difference in gender. I saw it's a woman and man quite equally attempt suicides with pesticides. It's the access. But the majority is young people. And almost 60% from our data that is limited with all the difficulties we have is brown and black people. So and they are not 60% of the population. So if we do not see that and we do not address that, we're also increasing inequities. So I think we should name the problems, and we should do what is in our power to do. So if we keep looking at the data and we try to see them as much as possible, improve the list that are under surveillance for the workers' health, so it's very important. And we had a lot of pressure for that, because they tried to apply the new legal rules to surveillance. I'm sorry, our mandate is in the Constitution, so we need to do surveillance. So they could not reach us on that. So we published the data when we publicized the data. So this is our power as well. So suicide can be prevented, and because we know if we do that, we are also preventing other types of diseases that are related to pesticides. Thank you.
Thank you so much. We have an intervention from Bangladesh? And name and affiliation.
Thank you for giving us these chances. I am Dr. Mohi. I'm working for the Prime Minister's office. I'm representing my State Minister of the Health, who is the head of the delegates and engaged in important bilateral meetings. So in Bangladesh, every hour we witness the 16 poisoning case. Not in a month, not in a day, in an hour, 16 cases. I'm not a researcher presenting the data, but I am the person where the policies are documented. So I know someone who who mourn for someone who don't have to lose. So I know the value of the lives due to this pesticide. But you know that we have also some good works on this. 25 years earlier, we banned the class 1 hazardous pesticide in Bangladesh. But still, we have high, poisonous case. So we have another national surveillance study where we found 21,000 cases in 10 tertiary hospitals. And we found one major culprit, that is the paraquat. And now I am personally dealing with the Ministry of Agriculture over the last 6 months to convince them to phasing out this chemical. And here I think this panel can help, this international community can help. If you speak out and if we can be the part of this joint statement, I think our internal debate will be easier to convince the Ministry of Agriculture law to having some ban on this agent. And we also need a very functional national poisonous center. We have a poisonous center, but don't that much functional. Also, we need some support or the international collaboration regarding the connecting this survivors with the mental health support, because sometimes surviving is not enough. So that we've proven our actions earlier, and we are committed to prove it again. So thank you for giving us these chances.
Someone in the room from Honduras? No? We have another intervention. Please name and affiliation.
Can I just come to the front? I was hoping not to speak today on this subject. I have spoken 5 times for the day. My name is Leslie Ramsamy, and I'm the former Minister of Health of Guyana. I thought I'd apologize for my minister who's across the hall speaking in another meeting. In Guyana, first let me address WHO. Your data in Guyana is totally wrong. The estimate that has been done totally, absolutely wrong. But data accumulation, data gathering is an issue. And I know we have to have an estimate, but I think when estimates are done by organization, it should be done with the country. Guyana in 2022 enacted legislation that decriminalized suicide. We have suicide in Guyana, about 70% are caused by pesticides. So pesticide is an issue. It's an agriculture country, and every Guyanese have access to pesticide, easy access to pesticide. When I was Minister of Health and then Minister of Agriculture subsequently, we introduced a system of pesticide storage with multiple locks on cabinets. And we are now doing a study to find out if it in fact had an impact. But there are areas in Guyana that were known as suicide capitals. mainly agriculture areas, that then went from suicide capital to zero suicide. And I can say confidently here that in the last decade, we have reduced suicide by more than 50% in Guyana. We established a gatekeepers program. In the gatekeepers program, we train people in the community, the pastor, the pandit, the imams, police officers, teachers, influential people in the community. They are our ears and our eyes. The people that might have issues that we could provide support to them. But suicide, like you said before, in Guyana is impulsive. The 30 minutes that you give, most suicide is impulsive. And if you try to align that with, say, the US or the European approach, that people that will commit suicide, you have the signs. And so it's very difficult in Guyana to do that because it's impulsive. So we are making real efforts to deal with this issue. And I could say that every suicide attempt and every suicide death in Guyana, we know because we have a surveillance system. And deaths in Guyana because of estate issues, etc. People it has to be documented. So we know all of the deaths where it occur. I want to end by saying this. Two things. And I think the International Association for Suicide are here. I spoke some time back in Trinidad. One, the language. I even heard today somebody say people committing suicide. Suicide kills people, right? And we need to be careful with the language of suicide. That's one. And two, the next suicide does not have to happen if we have all of the things in place. So I want to appeal to all of us. We need to take a step back. Why is it that some people, a lot of people have problems with jobs and so, but not all of us kill ourselves. And so I at some time ago in Canada, in Australia, and so they had this thing called follow back method. It's a kind of ante-mortem. So for people who die because of suicide, can we look at them from way back for years to look? We need to find something that help us to identify those who might be victims of suicide. So please, let's take a step back and let's look at this issue. Thank you.
Thank you so much. Thank you so much. A lot of perspectives. Since Michael Edelston is not here today, he unfortunately had to leave back for the UK. We may have a word from the Center for Pesticide Suicide Prevention and maybe also a little enlightenment on the resolution you could say you would like us to sign.
Sure, thanks everybody. So my name is Keith Tyrrell and I'm Head of Strategy at CPSP. I'm standing in for Michael because he's had been called away on a family emergency, sadly. So the first thing I'd like to say is it's a big thank you to all of our speakers today for sharing all their insights and their wisdom and their thoughts on this important issue. And a big thank you to you for being here. You know, the fact that you've come here out of all of the interesting, exciting side events that are around this event, it shows that this is an important issue, that it is a timely issue, and it's one that we need to address. The time to act is now. And I was trying to think about what to say, and one of the things that resonated with me is some of you would have been at the side event, the official side event in the WHO HQ on Monday, and there was one question which really got to the nub of what we're dealing with, is if there was one thing to do tomorrow for governments, for policymakers, what is it that you should do? I think it was asked by the WHO representative from Pakistan. And that is the question. That is the question that we need to answer. But the good news is that we have the answer. You know, we know that by eliminating toxic pesticides, we can get rid of about 20% of suicides. We know that works. The experience from Sri Lanka tells us that works. The experience from Bangladesh tells us that works. So just simply getting rid of those most toxic pesticides means that we can save lives. And the former minister from Guyana is right. This is about people's life. So what we need to do is we need, as countries, we need to go out and we need to identify those chemicals that are killing people. And the experience from Sri Lanka, the experience from countries that we work with, and we're working with dozens of countries now, is that the number of pesticides is relatively small. There are thousands upon thousands of pesticides out there. There are hundreds of active ingredients. Sri Lanka cut suicide rates by 70% by banning just 55 pesticides. And it's unsurprising when you put that in that context that there's zero impact discernible on agricultural productivity or output. We're not talking about all pesticides, we're talking about a very small subset that are extremely toxic. And we can remove those quite easily. The experience tells us that. So that's to answer that question that was asked on Monday. The thing you asked me, Fleming, was about the ministerial resolution. So one of the exciting things that also came out of that side event on Monday is that we have a draft ministerial declaration, which has already been signed up to by a number of the countries that are in this meeting. So thank you very much for that, for Nigeria and Guyana. And I invite every country present here to sign up to that declaration. There will be a QR code at the end of the event where you can access that and download it. So I'll stop there. Thank you.
And our representative from Bangladesh, who had to leave us, is so eager to sign up that he gave me his business card to get the QR code. Mark, maybe you have a few words to share with us. It's your daily work dealing with this. Maybe a few summary words.
Yes. I have actually even encouraged some people to come to this event because I'm so. There's so many events, and this one is so important. Why do I think this one is so important? I work in mental health. Mental health is an issue. It's complex. There's many causes for mental health, many interactions. If you're into mechanisms, we don't really fully understand them. The interactions, it's a complex thing. But there's only one area in mental health that is actually not so complex. It's actually very simple. And that is suicide prevention of suicides where the means can be removed. David Gunnell has a classic article which outlines this whole complexity, all the factors that go to suicide, probably gene, environment, interaction, all that. But in the end, the decision, the reality, whether somebody dies or not from suicide, is whether the means are lethal or not, and whether the medical care that they may get afterwards, whether that saves their life. The only factors. That's why in mental health we have no interventions in general where we can change prevalence rates of anything. You don't see any country saying we have depression is 12% now we do this huge intervention, and now it's 9%. I haven't seen it. It's because it's complex, there's many factors, and we struggle. For removing means of suicide, we see graphs and we see the rates dropping. that we see not only Sri Lanka, and congratulations to Sri Lanka, and you deserve all the credit you get, but maybe you're getting too much of the visibility because it's happening in many other countries where also means of suicide have been removed. And paraquat was removed in South Korea, and the suicide rates dropped. There have been drops in rates in China. And there was an attempt to have a World Health Assembly discussion on this topic, and it was declined because it was thought as a South Asian problem. But pesticide kills people in South America. It's the most common cause of suicide in El Salvador. In Africa, we don't know because there's not many data, but the suspicion is that also in Africa, it's pesticides that is beyond suicide. In Syria, war-torn Syria, people use insecticides for rat poison for killing themselves. It's the same category. So it's a global problem. It's 5 out of 6 regions of the world that I named now. So that's important. We sometimes struggle in our conversations when we advocate for this because some highly hazardous pesticides are necessary for vector control for malaria. But it's the acutely toxic ones within the category of highly hazardous pesticides that but anyone in public health should agree on that they shouldn't be around. They should be banned. And just banning them you need some follow-up. You need to ban. You need to make sure that that you discard them. You make sure that they don't cross you can ban. Some countries ban them and then still export them. I mean, it goes beyond that. Okay? Locking boxes was considered a good idea, and WHO even has, it happens. WHO, we keep all our guidance. We have guidance where we say, well, lock boxes is a good idea. Since then, a very large, strong, randomized controlled trial has been done in Sri Lanka. Sorry, Sri Lanka goes back there. Published in The Lancet, which is it's not so easy to get something, a randomized controlled trial in The Lancet, showing that it doesn't work. It's not the solution. It doesn't work. Why doesn't it work? Because if farmers, they will lock it maybe the first year, but do they lock it the second year? Eventually people, it's like, safety. People have to keep their behavior up. It's very difficult. We're human beings. After a while, think, well, nobody died last year, so let's leave it open, right? So that's how it is. So lock boxes is not the solution. The solution is banning acutely toxic, highly hazardous pesticides. So we are very supportive. I'm very supportive of the statement. I cannot say it on behalf of WHO. For that, you need to go for a resolution. But I can just say that I'm very supportive. The department is very supportive. We are very happy with the collaboration with all of you working on this, and we hope to see much more progress in the coming years. Thank you.
Thank you so much. We are getting towards the end of the session. Just interesting to listen to this when I digged into the data from my own country, Denmark, mid-60s. The first or second most common cause of death were acute pesticide poisoning. Across the country, more rural than urban, obviously. We have a big agricultural sector and so on. And within 2 years of banning the most hazardous pesticides, it was no longer a means of suicide. Mid-60s. I'm old. I'm from mid-60s. Then I travel young years to Sri Lanka, to India, to elsewhere, and I find a problem that has been dealt with in my home country are impacting hundreds of thousands of lives. And you think, why? We have known this, documented well, 60s and 70s from Europe. Why does it still take place? Exactly as just mentioned, phasing out, banning the most hazardous pesticides have worked in the 60s and 70s across Europe. Why wouldn't we believe it wouldn't work in Sri Lanka and many other places. Obviously, we need to share lessons learned across countries. As it was mentioned before, we need international collaboration to put pressure on international organizations, national political systems. We have pesticide suicides for no reason. So the convening of this particular event has been super important, because if we join hands, work across sectors, work across research, get good monitoring systems in place, we have the examples, we know it works, and it's systematically collecting the list of pesticides that kills in occupation related to suicide, and we find substitutes, and we see improvements in health. We have many examples that it works. We'll face opposition from vendors, from entities that are producing, marketing. We'll meet skeptics. All the food challenges will be brought up. The countries I know of giving 6 to 18 months to find a subsidy has worked, and it has reduced significantly occupational risk, accidental poisoning, and not least suicide by pesticide intake. So I think this has been super interesting. I really appreciate all the organizers for putting on the event. Of course, that also goes for the Center for Pesticide Suicide Prevention. Michael would have loved to be here. Unfortunately, he had to leave. He has worked tirelessly in this field for so many years, and I think a lot of credit also goes to his years-long efforts. I also agree with what was mentioned. We need to communicate this. It's not just a technical discipline. It requires enlightenment. It requires communication. It requires advocacy. But it's such a positive, you could say, outcome. I've been to so many sessions the past few days. Here we can act. We know what to do. We need to join hands and take action. Thank you so much for coming. And the further event I'll leave for you. If there might be more snacks available, I'm not sure.